My name is David Roth, and I'm from Lake Orion, Michigan. In 2001, I had a brain tumor. It was literally the whole side of my head. This needs to come out now or it's gonna kill you. The reality of it really didn't hit me till after the surgery. But my leg didn't work and I just started doing rehab.
When he first came in, he's someone who's had surgery in 2001. He had radiosurgery for this meningioma after that. They noticed he had another tumor growing up, not the exact same place, but near it. He had another surgery for that one. But now that you can see the tumor's been growing, and it's not huge, but it's in the same location it was before, and he's developed increasing weakness again. It's subtle. You could see when he walked in, he's limping on the left side, and the left hand doesn't work very well. The tumor board clearly wouldn't have any major new treatment for him. We had to do something besides just give him steroids, and another dose of radiation is probably not going to solve it for him. So the real question is, can we do something where we take out most of the tumor but don't make him weaker? We know roughly where it is, but which fibers are functional in there? A lot of them are, because he's walking.
He had his first brain tumor when I was 6. It was hard for me when he was first diagnosed with anything. I was young, I didn't know, I just remember being at a parade and my dad seizing out. He's been kind of dealing with it for the past 15 years now.
Heusen tensor imaging is actually a pretty intricate way to look at the white matter, which are basically the long parts of the neurons called axons as they travel from one part of the brain to the next part of the brain. The problem with DTI software historically has been it's been so clumsy and so slow. This stuff, technology's an amazing thing.
It's very easy to add, subtract, play around with the fibers and figure out a nice trajectory for where we're going. Normally, this is what we have the night before surgery.
Right.
You see there's a lot of lines, squiggly lines on there. So these lines represent all sorts of white matter pathways. If we had to go in an area like this is on the surface, this circle. So we can move it around until we find a way to go between fibers to get to where we want to go. Tomorrow, when you do the surgery, then everything gets set up again as it was planned tonight. And then we're looking at the top of your head, right? Okay. But we can't see this. But the software allows you to see it.
It made sense the way Dr. Rock was explaining it, all the different tracking and all of the different things that this new technology is doing. I think it's great that they are able to really sit there and map out almost everything they need to. If we had that prior, like my friend Ed's first tumor, probably couldn't have been able to avoid all of his handicap. As I was looking at it, I was just amazed. I'm excited for my dad's reaction. I'm excited to see what he thinks and what he says.
Surgeons love this technology, and it's for many reasons. It helps us in patient care and operational efficiency. To be able to walk into the operating room, to see the patient's brain in focus, and we can simultaneously map onto that where the function is.
We get a very broad picture on the image, all within focus. As you change the image guidance, automatically the point of view on the scope changes.
So we know not just where a lesion is or where the surface projections might be on the cortex. We can make sure that we perform a complete resection and understand the function of the brain at the same time. We can take what literally took hours and hours to put together. Imagine the brain with its billions of neurons and connections. We can actually generate these fiber tract images and display those fiber tracts seamlessly, almost in real time, within moments after generating those images. And that allows us to go from the theoretical to the real. We now, for the first time, have a real handle on turning historically, quote, inoperable lesions into lesions that we can actually attack. And the reason is that we can see what's around the corner, literally, and we can understand the anatomy that's involved to get to that very deep-seated lesion. And with this technology, we can plan that out. You know exactly where you are. That, in the end, makes all the difference for patients.
I probably know by the 1st of May if I'm going to improve greatly or it's going to stay the same. And if it stays the same, I just deal with it, you know. But if it improves, if I could get back out there and work, that would be fantastic.